I'm Dr. Craig Joseph.
And I'm Dr. Jerome Pagani.
And this is DocTalk.
In order to improve healthcare operations, many leaders understandably want to leverage big data. But before analysis can begin, it's important to realize that big data is not the same as lots of data. Consider the 4 V's. Volume. The volume of data created, captured, copied, and consumed globally is expected to reach 181 zettabytes by 2025. Roughly 30% of that volume will be healthcare related. Velocity. Data are coming at us faster. Internet of Things devices generate data every second, and the number of IoT devices worldwide is forecast to almost triple, from 9.7 billion in 2020 to more than 29 billion IoT devices in 2030. Variety. The forms of both raw and structured electronic health data keep growing, not to mention images, videos, and communications. Veracity. Trust is paramount. Data must be both accurate and reliable if they are to be used in meaningful ways for analytics.
To make good judgments based on big data, the data from multiple heterogeneous sources must be sorted, cleansed, and standardized. In the business, we call this ETL, extraction, transformation, and loading. A simple example from an operational perspective might involve moving information from a system that schedules nursing staff into a data lake containing principally EHR information. It's likely that unit names or even time of day might be stored in slightly different ways. These data must be transformed so that they're consistently represented in the same way. After the ETL process is complete, the real heavy lifting begins.
So how can good data drive better processes? Hospitals can focus on bottlenecks that decrease patient throughput, such as inefficient operating room scheduling. ORs are a precious resource, yet they're chronically underutilized, even when there are large case volumes. A recent study found that almost 17% of ORs had inaccurate estimates of time to completion, most of which were underestimated. Dashboards and proper analytic tools can identify trends such as operations that take longer than planned, chronically late starting surgeons, I'm looking at you, Dr. Fred, or rooms with deficient equipment that regularly delay procedures. On the clinical side, an enterprise-level example comes from the operational war room. Currently, the NHS is operationalizing data war rooms in preparation for the winter respiratory season. Leaders of a network of hospitals can see available beds and admitted patients awaiting assignments. The data requirement for a macro view will, by definition, require more data from more varied sources, which requires a modernized architecture and ETL process. A micro view might entail following antibiotic stewardship progress at a single institution where all the data are found in a single EHR instance, a much simpler proposition.
It's important for healthcare leaders to understand the 4 V's of big data: volume, velocity, variety, and don't forget veracity. When the data are identified, they must be manipulated via ETL so that apples are compared to other apples in an efficient and automated way. Finally, realizing that real-world applications often require both macro and micro views allows the proper questions to be accurately answered. While most executives won't be manipulating data themselves to create dashboards and other analytic tools, they need to remember the programmer's rule: garbage in, garbage out. Decisions won't be evidence-based if the data upon which they rest are suspect. So I agree, it's very confusing. I don't really understand it. Let's see if we figure it out together. So you get a kilobyte, and you multiply that by 1,000, you get a mega.
Are you trying to explain what a zettabyte is?
Oh yeah.
It's big. It's like Midnight's big.
Yeah.
Tom Hanks and Big. Med school student loan big.
Oh, that is big.